Okay, so I've got the amazing job of hosting the panel, which, you know, I'm in a sandwich between two amazing brains. Who else would want to be in my position right now? Now, we've had hundreds of questions, and sadly, we're not going to get through all of them, but what I'm going to try and do is get as much information from these two gentlemen as possible, and not forgetting myself and Amanda as well. And by the way, Jeff yesterday said that women are the new emergence of functional medicine. So come on, ladies.
So I have no answers. Just go.
Okay, so the first question is, what can you do? This is to you, Stephen. What can you do with adhesions for SIBO?
What can you do about adhesions? Well, what I do is I refer to physical therapists or massage therapists that do visceral massage. There are many different techniques for manually releasing adhesions, and the typical patient will take about 20 hours of visceral work in order to finish up an average case of adhesions in the small bowel and in the gut. But it works very well, and almost everybody that I refer for that comes back and says, wow, that was so important, so amazing what it did.
Thank you. And this is one for Jeff. I've got to read the writing here. What do you think about the controversy about whole grains? Are they good, bad, pro-inflammatory? Thinking of the books like Grain Brain.
Yeah, I think that this is a really interesting area of certainly controversy, and David Perlmutter and I are great friends. He's now traveling Alaska right now on what used to be our boat, which is now he and his wife's boat. So we're sailing in the waters, but we go to different destinations. I think that the Grain Brain concept and its connection to Professor Fasano, who, as you know, is one of the world's experts, obviously, in gluten, is absolutely on spot as it relates to the hybridization of grains and the changing of the protein content of grains over the historical cultivars. And over time, what that has done is it's increased, I think, the antigenicity of our grains. I don't think it's natively part of gluten in and of itself when we get these non-gluten specific inflammatory conditions. I think it's a relationship to a whole variety of different constituents of the grains that have been hybridized over time. You can see this with people that go to Italy from the States and they eat the original cultivars of wheat and they don't have the problem. So I think this is a complex interface between the way we have raised and processed grains and the nature of people's GI systems that are already in a state of pro-inflammation because of dysbiosis. And my feeling is it's not so simple as just to remove gluten from all grains, gluten from all foods. I think that there is more to the story than that. And I think that the connection of the gut to the brain is more than just gluten.
Thanks, Jeff. That's a great answer. Amanda, this one's for you. How do you tackle a sugar addiction?
Well, I do the timeline, like I was talking about. Try to understand the association they have with sugar. So, in other words, where did that maybe first begin? So let me just tell you a very quick story here, because I was fed sugar when I was in hospital ill. That was my first taste of free sugars because I had a sugar-free diet. So my association is very negative. It's been an easy thing. So I kind of ask around those things. What does sugar mean to you? What does sweet food mean to you? Trying to find that relationship that they have. And then I would follow a protocol, and sometimes it takes a long time, sometimes it's very quick. Support in all ways, but look at stress as a key factor there, because no matter how clever, knowledgeable somebody might be, when they're under stress, they're driven to look for that quick fix. So try to educate around that piece. And as I said, sort of liberate them from that.
I think that's a great response. And I think also, though, we've got to consider helping them with additional supplementation. You can't just say don't have sugar, can we?
No, it's the whole
Using
piece.
things like cinnamon, chromium, alpha-lipoic acid. So we've got a great product at Nutri called Glucochrome, and it kind of captures it all together. And I find that utilizing that with the behavioral changes is a great coherent package. And it might be after 4 to 6 weeks, they don't need the supplement. The behavior is enough. But we've got to get, it can be a lifelong addiction. And we all know that sugar is more addictive than cocaine. Is it possible, Jeff, I'm going to put this one over to you. Is it possible to reverse Crohn's and colitis even after surgical intervention? Well, either gentleman, actually.
Yeah, I think Stephen should probably be the first to shoot at that, and I'll fill in the gaps. Why don't you go first?
So, post-resection, person is still not doing well. In Crohn's disease, in the United States, sometimes they use the term cure. It's the only cure, is resection for Crohn's. Otherwise, they don't use the C word. So if that doesn't do it, removing the organ that's supposed to be the part. Now, of course, people can get recurrences in new places. And I assume that's maybe what somebody's talking about. If we're just looking at the disease. So if the underlying factors haven't been dealt with, if the gut bugs, if the yeast, if the small intestine overgrowth, which is very much associated with Crohn's, because of the thickening and the slowing down of the motility in the small bowel, that can be a major factor. One thing that's really important to understand, too, is in Crohn's, I'll say this quickly, Crohn's and SIBO, because they're paired in many patients, the problem is the symptoms of Crohn's, they don't have to be like ulcerative colitis. There doesn't have to be any visible blood. There doesn't have to be any diarrhea. It could just be abdominal pain and or maybe some constipation, occasional diarrhea. And with those kinds of symptoms, if the person is actually in a flare of their SIBO, the exact same symptoms may be there. Pain, some alteration in stool, bloating. And so you really have to differentiate, is this a flare of Crohn's or is this a flare of SIBO? And one way to do that for some patients is just to check their calprotectin level, check their fecal lactoferrin level, and see how high is it. And if it's just in the normal range or under 250 for sure, that doesn't really look like a flare. So you have to differentiate. And gastroenterologists, everything they see is inflammatory bowel disease because that's the diagnosis. But if you have more than one thing going on, yeast overgrowth, bacterial overgrowth, other things going on in their life, stress and coping that needs to improve, then those have to be addressed too.
Perfect.
I would just offer one little fill-in. And I think it was 1996, there was a very interesting paper published in The Lancet. It really struck me on this topic, in which they were looking at recidivism of attacks of Crohn's disease after hospitalization and successful surgery. And they did a study looking at post-discharge gut permeability using the lactulose mannitol test. And they found that individuals who were discharged with a non-permeable gut, based on the lactulose mannitol test, had less than I think it was 20% probability of relapse in the first year. People with a high lactose permeability index, meaning a leaky gut on discharge, had over a 90% relapse rate. And then you ask the question, in surgical procedures, how often before discharge are patients' intestinal permeability measurements made? So if you don't ask the question, you don't get the answer.
Indeed.
So if you have a permeable gut and you don't do the things that Stephen was just talking about, then you end up being a high candidate for readmission.
Brilliant. Now, this is a great question, and I think, Manda, this might be one for me and you. As nutritional therapists, we have the skills to provide the basis of future personalized lifestyle medicine, but most mainstream healthcare practitioners and the public assume we do little but eat more salad. Should we be calling ourselves something else? How can we easily and simply and more accurately convey what we do to those who don't know what they don't know? And we have to sing to
That gets a shout out.
Say,
That's a shout out.
no, you can sing. We've got to dance now. Oh my goodness. What can we call ourselves? I think hopefully we're beyond that.
Yeah.
I think that maybe was 15 years ago. It was really challenging 10 years ago, 8 years ago. But I have a lot of hope, actually more hope after this conference from speaking to people, from listening to you all. And I think it's more about being less apologetic, about the knowledge base, about the experience base, and maybe a bit more provocative also. Maybe it's that time.
And I would also say it's showing people that we are practicing science-based medicine and that we're not just pulling eat more vegetables and fish out of our pocket. It's actually saying there's evidence behind what we are saying. And whilst most of my clients don't necessarily want the research paper, they want the belief that what you're asking them to do is to make a difference. And another question came in like, how do you sell supplements? How do you get it across? And I think you've only got to show them the evidence, the data, and actually the cost goes out of the window. Like that client knew that he was drinking too much alcohol but put nothing into it. As soon as you show him the evidence of his ill health and he's like, I'm going to do it. So I think that's where we can show people what it is that we are trying to deliver to them. And that's the difference between an old school nutritionist and a nutritional therapist and a functional medicine practitioner that has the amazing skills in their pocket that we've all heard today.
Yeah, I reference every single thing I give to the media, always. So they don't print it, but it goes in as referenced.
Yeah.
So it's
I'd
that
like
backstops there.
I'd like to just add one thought to that. And, as kind of a student of history, I look back at great cultural changes that have occurred within healthcare over the last century or two. And if you really ask the question, how did nutrition even become part of the lexicon of health? It wasn't driven by licensed health practitioners at all, right? In the United States, it was driven by Sylvester Graham and Howard Thompson, who had the Thompsonian health movement that was a woman-centered movement by word of mouth across the fences of their homes about what to do. That drove from consumer activism medicine to make changes. And it actually, in response at first, it led to the American Medical Association to try to hold down the woman-centered health movement that was saying doctors will hurt us. And so I think that if we really look at how these transitions occur, of which we're engaged in one right now, it doesn't occur from the top down, it occurs from the bottom up. And then you find the enlightened individuals who are the early adopters that provide the services, who ultimately everyone says, oh yeah, I was always there. But they just get pulled in by the weight of consumer power. And I think that's what's happening right now. And social media is a big driver. You can't hide anymore. This concept of being kind of isolated, where you were the keeper of all information, you were omniscient, and patients came to you on bended knees as victims to be rescued, those days are over. Now, as you probably know, there's this book that was a bestseller in America written by actually the most highly published American medical researcher, doctor in the United States. It was called The Patient Will See You Now. The Patient Will See You Now. I want you just to think about that title, because that is the driver of change. There's so many people worried about being judged. I think we ought to just put that to rest and do a good job, because the proof will out, because consumers are on our side and the field is coming to us. We don't have to go to it.
Amazing. Do you think artificial intelligence will revolutionize personalized lifestyle medicine, systems biology, and all the data we can now generate via the genomic, metabiomic, microbiome studies? Now, Jeff, you answered a very similar question last night, so I'm going to put it to you, because that was an amazing answer last night that obviously most of our delegates didn't get to hear.
Yeah, so those of you that were around, and there are many people I can see in the audience who are the right age, that you were around back in the transition of the 70s into the 80s, where Steve Jobs and Wozniak were in their garage playing around with what people called a hobby, which became the microcomputer revolution. The Alltech computer was a hobby from which they scaled to build the Apple computer. And by the same time, interestingly enough, you had two other guys in Seattle, Washington that were hanging out, Bill Gates and his partner, Paul Allen, who were developing the software that ultimately did the impossible and took over IBM as the singular most important discovery in mechanizing society, world community. So you had Microsoft and Apple, these two interesting giants. Neither of them grew out of an interest in people wanting to be involved with computing. I mean, if you were talking in the 1980s about, do people want computers? They would say, no, I don't want computers. No, that sounds ridiculous. Now the thought that we would live without computers, we're all running around with our cars, our smart devices, everybody, you don't even think about computing because the technology has been made so user-friendly and so convenient that it has made our life simple and we don't have to become computer geeks to use the technology. That's what's happening in healthcare. All this stuff the early adopters are playing, the biohackers, I'm one of those, I'm kind of a biohacking nerd, obviously. Those ages of the few early adopters who think of this as a hobbyist thing and trying to forecast and understand this technology will make this technology just as what happened with microcomputers, where we started to develop the graphical user interface and making it simple for people to use, so they didn't even think about computers anymore. This large data cloud that's going to follow us around, all of us, we won't even know we're doing computing. We won't even know our information is being stored. We won't even know how it gets processed. It'll come to our smart devices. It'll coach us. And I was just saying with even this simple little device I'm wearing on my finger, having tried now over 20 different kind of biosensors over the last few years, this one to me is really emblematic of the progress that's being made because it goes to my smart device and it coaches me. So if I want to do 10 minutes of relaxation in an airport, it'll ask me, how do I want to be coached? And I can sit there in an airport and it'll get my biorhythms in sync and my heart rate variability will increase. I just saw that in the Singapore airport the other night at 2 in the morning. I was trying it. And it'll also teach me about things that I've told it I want to practice and I want to get better at. It'll give me alerts. It doesn't do that by me thinking that I'm becoming a biohacker. It does so as a tool to facilitate my objectives. And I think that's what's going to happen with all this data as it becomes consumer friendly, and we won't even think about it as being part of this techno-nerd revolution.
Amazing. This one's for you, Stephen. How much of the SIBO treatment, whether it be antibiotics or herbal interventions, can you apply to children?
We treat plenty of children. There are liquid supplements. There are homeopathic treatments that, of course, are great for kids. And we might have a little trouble with most of the prokinetics in the period of prevention, except that there are some liquid ones that can be hidden pretty well. So yeah, we do have liquid options for treatment that we use with kids. And I also have a number of kids that have G-tubes because they've had so much surgery on their gut. And it's really easy to treat them because you just put it right in.
Yeah, and I would say in the UK we've got herbal supplementation that's very easy to deliver to children in tincture formats. So I think it's quite easy for us to have availability. I think this is a free-for-all. Should you always follow the 4R protocol in the order it's stated? Remove, replace, re-inoculate, repair. I'll let you start, Jeff, because
No, I don't think you have to follow that in an order. I think what you have to do is try to accomplish those 4 Rs. And a lot of this is we've all been talking about, and you already know, is related to compliance and adherence. And the person has to own their own program, right? We're not going home with them. We don't wire their jaw shut. We don't sit at their knitting table with them. They have to own the program. And so whatever they're going to comply with and they're going to adhere and make part of their life that accomplishes those 4 Rs, that's going to be the program that works. The best theoretical program in the absence of application doesn't do much good. So I'm a big person around behavioral flexibility and asking a person, what are they willing to do? If they're not willing to do it, I can sit there and speak until I'm blue in the face, and it probably just wasted hot air. So I think the R's are instructive as guidance tools, not as sequenced regimentation.
And I love that word, flexibility, and I think that's what becomes most of the guidance to my programs. And certainly when I'm working with SIBO clients, there is not an often distinctive end to the remove phase, because you can move through the next stages and then you feel the proliferation of the bacteria mount again. So it might be you need to keep more like a lower level antimicrobial whilst you're trying to do the repair work simultaneously. So it is, that's an amazing word, I think, that frames that response, is flexibility. This is one for you, Stephen. In SIBO clients, what is the best approach in adding back in probiotics after the kill-off? Does soil-based probiotics have a good enough effect, and how long before you can put in the other strains?
So probiotics, big question, especially with bacterial overgrowth that can be associated with lactobacillus overgrowth. What I tell people is we'll generally wait until things are improved, and then if they want to try a probiotic, we'll use one without prebiotics, without FOS and inulin and things like that. And we'll see how they do with it and start with a low potency. Certainly with soil organisms, I like to start the lowest possible dose every other day and see how they do. And it's all about their individual response, whether we're going to go with it or remove it.
Okay, fantastic. What's your opinion on the Viome test?
Viome is a very interesting company. You're probably familiar with. I could give you all sorts of stuff, but let me keep it at the high level here. Their technology is metatranscriptomics, right? Rather than measuring the genomic signature of shotgun genes within the complexity of our microbiome, which means genetic analysis of all of the genes that constitute the bacteria in our gut and archaea and all the other organisms. What they do is they're looking at how mRNA is produced by the activation of the genes in the bacteria. So they're saying they're measuring the activity of the bacteria, the microbiome, rather than just the nascent bacteria that are present. And I think there are positives and negatives to that. The positive is that you're looking at a functional aspect of the microbiome at the moment that you capture that information from the stool. The not so, well, a different way of looking at it is that if you were to take repetitive stool samples over the course of the day, you would get very, very different transcriptomics, because they change based on all sorts of things, because your bacteria are turning on and off their genes in real time throughout the day. So you're not looking at the whole nature of your pluripotentiality. You're just looking at what happens at that moment that you've captured the stool. And as Stephen pointed out earlier, the stool is really coming out of the flux. It's not the stool of the bacteria that are sitting right up against the mucosa that are activating or affecting the immune system of the gut. So it may be a surrogate marker, but it's not like taking a mucosal biopsy right near the gut, where you're really looking at the bacterial activity that are affecting the immune system at that moment. So I think it has positives and it has negatives. Some people have said the best way of doing this, and I think a lot of the labs are now moving this direction, is to do shotgun metagenomics of the full genomic screen, but then couple it with metabolomics, so that you're actually looking at what the metabolites are that are produced as a consequence of the bacteria that are present that are doing the job. Because metabolomics will tell you then the business end of what the outcome is of those activities that are going on in the gut. And so you're kind of hedging the bets between potential and functional activity by doing the combination. And that's really where the technology is going. The reason that we haven't been able to do a lot of those until recently is it's a huge informatic challenge. You've got, imagine all of that data from the genes of all those bacteria, plus all the data of all those metabolites, and then putting that together into an informatic program requires some pretty high computing power. But that is becoming available now. The frontier labs are starting to offer that service.
Thank you. So I'm going to finish with two more questions. Stephen, what time frame would you treat SIBO for? How long would you do the removal stage, and how about the maintenance stage?
So it depends. That's why I like to have a test. Some doctors say, oh, well, let's assume it's that, and we'll treat and see if they get better. For me, that's a recipe for a big mess a lot of the time, because if they don't get better, you don't know if the treatment didn't work or whether the symptoms they had in the first place were or were not SIBO. It gets really complicated. So I like to start with the test. I like to treat based on what's there. So let's say someone has severe SIBO, meaning gas levels over 100 parts per million when you add the two together. We tell them the average decrease parts per million for 2 weeks of prescription antibiotics is 25 to 35 parts per million in our experience, and the same thing for a month of herbs. So if they're over 100, you can't really expect them to be done after a month of herbs. They're only going to be in the 70s if you're lucky. And then another month, they're still going to be above 15 for the combined gases, or 20 for the hydrogen. So usually in cases like that, we'll do 2 months of herbal therapy, wait 2 weeks while they're on a prokinetic and the diet, do another test, see where they are. Unless they're 90% better, and like the protocol said, you don't have to bother, just do prevention. So the prevention stage depends on whether they have autoimmune IBS with antibodies to vinculin or cytolethal distending toxin. Then, like I said, I'm going to really be doing it for years. Yeah. And of course, treating the underlying cause before or during treatment as well. So it kind of depends on how high and what gas. Methane can be more complicated to treat, just depends.
Thank you. And finally, what is the future for functional medicine in the UK over the next decade? Thought I'd save that one to last. Jeff, do you want to say what you perceive the future to be over the next decade?
Yeah, I think Amanda did a really great job, and I compliment you in kind of describing a landscape of how this biobehavioral aspect that we call functional medicine will gain more and more reception and become more sticky. If you really think of what we mean by function, and I'll just quickly state what could be a long-winded diatribe, that function really is divided into, I think, 4 quadrants. One is physical function, which has a lot to do with the nature of the human body, how it's constructed, muscles, bones, ligaments, tendons, all that stuff that leads to function at the physical level. The next is metabolic or physiological function. We spent a lot of time talking about that aspect and looking at biomarkers and biometrics and how the body's inner workings controls outside exposures to inside function. And then the third would be cognitive function, and that is this thing that sits on the top of our spinal cord that has this extraordinary ability to move us forward and backward in time and create scenarios that are greater than any supercomputer could ever come up with, just going and thinking about the great geniuses of the world that come up with these things that you'd never be able to do by random thought. Those are pretty remarkable powers that we have in our cognitive function. And then lastly, and one that Amanda really spoke to, I think is very important, is there's the behavioral factors, the emotional, behavioral, psychological factors, the locus of control, self-efficacy, feeling of worthiness, love, connection, spiritual reason for being. All these things are part of our functional integrity. And when you put those things 4 together in the right way, it makes a complete human being. And it moves us out of the hospital, it moves us into high levels of capability and long, healthy life that's bounded only by our imagination. If any one of those 4 quadrants are out of balance, then you start to have a flat spot on the tire and it runs less smoothly, right? So if you have 3 of them out of balance, then you're really having a problem with your differential in your automobile of your life. So I think that, to me, functional medicine is a biobehavioral approach to activating the pluripotential that we all have in our genes to be great. I have never met in my life someone that I got to know them wasn't in admiration of some skill or talent or ability that they had that I wish I had more of. And so it's a question of how do we bring that on in people and make it really resonant, because that becomes a healthy society that then serves its posterity the best as possible.
And I think I'd just like to finish off by saying the bit about the UK. I remember when I graduated from IFM in 2013, people said, yeah, but it's easier in America because they've got an insurance model and they can have their prepayment to see their functional medicine practitioner. And here people have to put their hand in their pocket. And I think the movement has gone away from that. And sadly, with the NHS being at desperation levels, and I only had a BBC alert on my phone a couple of hours ago about the failure of cancer hitting the deadlines, like not enough people are hitting the waiting time for cancer patients. It isn't a case of finances are a limiting factor to functional medicine nowadays. Functional medicine is on fire in the UK, and you, ladies and gentlemen, are part of that movement. And I would say those of you that are just entering this world is go out there and make a difference, because the UK really needs each and every one of us to be there to make a difference with the science that we've explored today.
Hear, hear.
So I would just like to say a fabulous thank you to our speakers today. So if you could all join me in just giving them the appreciation.